Chambers, and with that, we will have roll call.
Wade.
Here.
Festerson.
Here.
Espinoza.
We'll go to approval of the minutes for the roll call.
Wilkin.
Yes.
Wade.
Yes.
Rogers.
Yes.
Jones.
We'll go to now
Oh,
action.
hang on.
Sorry.
Oh, Espinoza isn't here, sorry, and Festerson.
Yes.
Okay, thank you.
We'll go to the action items. We have items A through P. Does anyone need to pull anything? Hearing none, is there a motion to approve items A through P?
So moved.
Motion by Wilkins, is there a second? Second by Wade. Hearing no comment, roll call.
Okay. Festerson.
Yes.
Rogers.
Yes.
Wilkin.
Yes.
Jones. Wade.
Yes.
Okay.
Item 4 is presentations. Item A is the fetal infant mortality review, baby blossoms. Who's up?
Good morning, Board. Jamin Johnson, Division Chief of Public Health Innovation Strategy and Planning. The Fetal Infant Mortality Review Team the program itself sits within the division I oversee. And I want to give the floor over to my teammates. So I want to introduce Akshay Salvarika-Miraj, Amanda Blumenkamp and Diana Ortiz so that they can walk through the FEMUR program, kind of give you an overview of where we've been, where we are, and where we plan to go in the future. And then I will stand for questions should you need me.
All right, good morning, everyone. We are excited to share more about the Fetal and Infant Mortality Review program process and what we've been working on. Okay, so this is a FEMUR team. As Jamin mentioned, we are housed under the Division of Public Health Strategies, Innovation, and Planning. My name is Diana Ortiz, and I am the Community Action Team Coordinator. Amanda is our Case Review Team Coordinator, and Akshay is our epidemiologist. So we thought we would start off with talking about the different types of death review processes. We just want to quickly explain where FEMUR fits. So child fatality review is the broader umbrella. It includes reviews of all types of child deaths. FEMUR is one part of that. It focuses on just fetal and infant deaths. There is also a separate process for maternal mortality review, which looks at deaths during or after pregnancy. FEMUR may overlap slightly when there's a pregnancy-related infant death or shared risk factors, but MMR is focused on maternal death specifically. There's also other types of death reviews such as overdose or opioid fatality reviews, looking at overdose-related deaths across age groups. These may also intersect with FEMUR if substance use was involved. But the lens is broader. FEMUR is not a medical review. As many of you know, hospitals and health systems do these reviews, such as quality assurance and peer reviews. FEMUR looks at the bigger picture. So it looks at what happened across systems, including social and community factors. One of the biggest differences is FEMUR includes the family's voices, which most other reviews don't. FEMUR seeks to understand what lies beneath the surface of each fetal or infant death, not just what happened, but why it happened. We bring partners together to examine contributing factors like poverty, chronic conditions, toxic stress, structural racism, and gaps in care, not to assign blame, but to identify system-level opportunities for change. As Dr. Art James has said, Nebraska is in a unique place to eliminate the disparity. Black births are largely concentrated in Douglas County, and the number of infant deaths is relatively low, which means that achieving racial equity and infant mortality is within reach. So this gives us even more urgency and meaning to our work. So here's a breakdown of the two teams involved in the FEMUR process and how they each play a role in making the change. So we have the Case Review Team, or CRT, which is made up of people who are directly connected to the community. So this includes service providers, care coordinators, and people with lived experience. Their job is to review the de-identified case summaries, look for patterns, and figure out what systems or services may have broken down. They help us understand what's working, what's missing, and what could be done differently. And then we have the Community Action Team, or CAT, is made up of people who actually help make those changes happen. Our CAT is formerly known as the Baby Blossoms, and we'll talk about those changes here in a few slides. But the CAT is made up of leaders from agencies or organizations that can shift policies, programs, or fundings. They use the CRT's recommendations to decide what action to take and help move those ideas into real solutions. They also let us know what's working and what's not. So to keep it simple, the CRT helps us understand what happened, and the CAT helps us do something about it.
As Diana said, I'm Amanda Blumenkamp, and I coordinate our case review team. And so I just want to walk you through real quick how the FEMA process works, very briefly. So it starts with the death notification. Vital Statistics notifies us of the fetal and infant deaths. Infant deaths are considered a live birth regardless of gestational age through 1 year old. And then fetal death is a stillbirth greater to or equal to 20 weeks. And I just wanted to correct that from last month. 20 weeks is the official threshold for fetal deaths. And that cutoff comes from how they're defined in vital records. And it's also Nebraska's and the national standard for how it's defined as. So we wanted to align with those national standards. So we do case identification. Currently, we prioritize cases where there's a family interview. However, we know that eventually we will run out of interviews. And so we're looking at doing something that the health department has done in the past, at adopting the PPOR, or the perinatal periods of risk model, to help us guide our case selection. Then I collect records from a variety of sources. This comes from medical records, social services like CPS records, autopsy reports, EMS and law enforcement records if that's applicable. We do have to wait until an investigation is completed before we would review that case. And then, as Diana mentioned, family interviews are really the heart of FEMA and what sets it apart. And families are offered a chance to share their story in a voluntary interview, and this provides key insights into their lives and the experiences they faced during the perinatal and postpartum period leading up to the infant death. And I'm going to talk a little bit more about that in the next slide. Then the case summary. So then all of the records, including the interview, if we have it, are turned into a large de-identified case summary, and that brings all of the medical records, the social and the system level picture together, and then it's disseminated to our case review team. Then each month we hold a case review team meeting where our team comes together to identify really present and contributing factors, not really focused on the cause of death, and we develop system level recommendations. Then the community action team takes those recommendations to move them forward into actionable items into the community, and we're working to make sure that that's a closed loop system so that the community action team then reports back to the case review team. And so I want to talk about family interviews. This is something that we're really proud of, and one of the things that drew me to this work as the FEMA nurse is my passion for perinatal bereavement. I've spent time with probably nearly 50 families in the hospital who are saying goodbye to their baby. And while some people think it's unimaginable, for me it's been an honor to be in those spaces, and it really grounds me in the work that we do. So family interviews are a way to elevate the voices of families who have experienced this type of loss, and oftentimes it's their first and only opportunity to tell their story. As we know, fetal and infant loss isn't broadly accepted, and so many people are uncomfortable talking about it. Through this, the interviews are voluntary, and they give families an opportunity to share what happened from their perspective, what helped, what didn't, and what systems could have done better. Now, these interviews are really hard to get. Nationally, many FEMA programs struggle with this, and many FEMA programs nationally have just stopped trying to get these interviews. But we decided early on that if a family is willing to share their story, that we have a responsibility to listen. So one of the things when I came on board into this role is I made a change into the outreach process. So previously, we only contacted families once a case was selected for review. But it was really important to me that if someone was brave enough to share their story, that it should be a part of how we decide to review their cases. So now we send outreach to every single family, and that starts with we mail a sympathy card and an invitation. It's not a generic sympathy card. They're made for families who have had a loss, and we invite them to share their story, and we make sure that it's in their preferred language. If we don't hear back from them after a few weeks, we send a discreet text message just about a recent loss, and then we give an option to opt out or reply with the wrong number. And then a few weeks later, if we still don't hear, we just send a closing letter, and we make sure to include mental health resources and grief resources so that they have what they need, even if they don't participate in our interviews. And then we send a questionnaire. That way, if they do have something to share, they can share it on their own time if they'd like. So my goal this year was to complete 10 family interviews, which I knew was really ambitious, but probably one of my biggest accomplishments is our team has completed 7 interviews so far this year. And I've done 6, and then one of the coolest things is since Diana speaks Spanish, we were able to do an interview with a Spanish-speaking mom who was able to tell her story without having to use a translator or interpreter, because that takes away a lot of the human touch. And her story was really impactful. So behind these interviews, they really remind us that behind these numbers, there's a real family there. And that's what drives us to do our work, is these interviews.
So we wanted to share with you all this health systems map that we use. This really helps ground us in how we look at our case reviews in our case review team meetings. We aren't just looking at how the systems are interacting with the family at preconceptive, interconception, and postpartum levels of care, but we are also looking at the interconnectedness of the systems themselves, how they work together, are there any gaps in care between the systems and the family. For example, are referrals being given? Are they being followed up on? Really just what's working well and what isn't. Here we have a table that looks at infant births, deaths, and mortality rates by race ethnicity in Douglas County from 2021 to 2023. The 2023 data specifically is provisional and subject to change, and the black boxes you see are suppressed data due to counts less than or equal to 5. So for each year, we have columns that represent infant deaths, live births, and an infant mortality rate for the year. With those, so 2023, you can see the numbers are a little different, and that's because we added multi-race as a separate category, and we moved the Hispanic ethnicity into each of the races to provide a little bit more granularity. So you'll see white not Hispanic, white Hispanic, black not Hispanic, black Hispanic, etc. And so with those infant deaths, live births, infant mortality rates by year, we calculated infant mortality disparity ratios based on the 3-year average, and we used white populations as the baseline, with them having the lowest infant mortality rate. And with that, the black population has a disparity ratio of 3.572 over this 3-year period, and Hispanic populations have a disparity ratio of 1.007. Here, we just wanted to show a visual aid of what fetal and infant deaths by zip code look like for just 2024. Again, this data is provisional and subject to change. And I do want to say that this is looking at fetal and infant deaths, while the previous slide was looking at just infant deaths. So you have the top 5 zip codes here available to you, but I also want to say that this is just 1 year's worth of data. It's hard to draw any meaningful conclusions from it, but what we hope to do is look at this by year, by zip code, for the previous 15, 20 years, as well as moving forward, so we can really see where the deaths fall and if there are any trends that come out from the data.
So Akshay, this is 1 year worth of data under the new categorization. Okay.
Yes. For this 2023, yes, new
Okay.
categorization. 2021 and 2022 don't have multi-race, and Hispanic is listed separately.
Okay.
So previously, with that data, previously it was captured if maybe someone was considered Black, Hispanic, they were only captured under Hispanic. And we felt like we were missing something if we were missing the multi-race population. So that's why we wanted to break it down a little bit more. So I just want to, this slide kind of talks about, and I think this is what you want to hear, is it gives an overview of the progress that we've made in our program over the last 11 months. I started last August. We've improved how we review cases. We're working on rebuilding trust in the community and really laying a stronger foundation for action through our community action team. And I want to highlight that equity is really at the heart of everything that we do. It's not just something that we talk about in our reviews. It's really built into how we approach every part of the program, how we reach out to families, how we choose partners, and how we develop recommendations. And a big reason we do this is because we know that disparities exist. And I just want to highlight something that Dr. Michael Liu said, is that we have to save Black and brown babies at a faster rate. It's not because other babies don't matter, it's because Black and brown babies are dying at a faster rate. And so we think about things like systemic racism, cultural barriers, and the social conditions that families face and that affect their care and their outcomes. So back in November, the National Center for Fatality Review came to Omaha to help lead us through some strategic planning, and they helped facilitate our first case review team meeting. That visit really laid the foundation for how we structure our reviews, and it gave our team the training we needed to move forward. We've also taken part in the Title V needs assessment, and we shared our program during a panel at the MCH Summit in Lincoln. I do want to say that one of our biggest wins this year was Akshay built a REDCap database that mirrors the National Center's system, and their team told us that no local program has ever been able to do that. And this gives us access, real-time access to our local level data by having our internal database. So we've reviewed 5 cases this year. Just yesterday, we held a mid-year synthesis, and we identified some key themes that showed up in every case review. Some of those themes were mental health, grief and trauma, care coordination, postpartum and interconception or between pregnancy care gaps, and some of the chronic condition management that happens during or after pregnancy. We identified those 5 themes happened in all of the 5 cases that we reviewed. 4 themes identified in all the 5 cases that we reviewed. So in that meeting, we wrapped up by voting on 2 recommendations to move forward, and those came out to be creating care navigator roles to support families and reduce barriers, and standardizing perinatal education, not just for families, but also for providers. One of our providers highlighted that families need to know that providers know they're at risk. And how do we relay that to them? And how do we make sure that all providers know that they're at risk? So it's not just a family education, but it's also at a provider level too. Internally, we've made some changes behind the scenes. We've structured our femur team and we brought more voices to the table. We really wanted to include people with lived experience, both in our case review team and our community action team. And we moved our case review teams to the health department. And then previously, records requests happened and you received thousands of pieces of paper. Now we've tried to standardize some of those to getting some digital copies. And over the last 11 months, we've really focused on rebuilding trust and relationships in the community, especially after FEMR had gone quiet for a while. We've held 6 case review team meetings and 2 community action team meetings. And we really relaunched community-centered efforts. One of the things we did was we did a holiday donation drive with A Mother's Love. And then to support our momentum, we designated a community action team coordinator, and we're building a stronger structure to focus on long-term systems change. Our community action team was previously called Baby Blossoms, And in that structure, Baby Blossoms was the overarching umbrella, and FEMUR kind of fell under that. When we did our strategic planning, we decided that our community action team would no longer be referred to as Baby Blossoms. We are called the community action team. FEMUR is the overarching umbrella now, and the case review team and the community action team are under that. And we want to ensure that the action team stays action-oriented rather than a networking event. And so all of this really gives us a solid foundation. A lot happens between our meetings, day-to-day behind the scenes, that helps us create a sustainable program.
Okay, so just to wrap us up, there's a lot on the slide, but we did want to include what goes on the day-to-day in between our monthly CRT and our quarterly CAP meetings. Our FEMUR nurse works diligently to identify and abstract cases to have them ready for our CRT, and constantly reaching out to families for interviews and finding ways to improve that system. Our team also meets regularly to stay coordinated. We use our REDCap database, which our epidemiologists built from scratch, but it just really helps us to track cases, pull data, and look at both numbers and the stories. So like what we learned from family interviews and from our CRT discussions. And then other than that, we are continuously updating our internal work plan to reflect where we're growing, what needs more attention. This includes reviewing our CRT and CAT membership to make sure we have the right mix of voices at the table and that we're staying responsive. This year, we're really focusing on building the CAT's capacity, not just by inviting partners, but by thinking about what support they'll need to help turn the recommendations into action. We've been doing this assessment, which is in the form of a short survey to our CAT members that helps us understand what are their roles, what services the organization provides, and how they might support this work. This helps us gives a clear picture of what already exists in the community, and what we can build on, what might still be missing. We're continuing to grow our knowledge and skills through ongoing education with the National Center. We are expanding how we share our work more broadly. So we submitted an abstract to the City Match Conference called Reinvigorating FEMUR, Policy and Practice Hacks to Drive Success, and it was accepted. So we will be co-presenting with Dr. Abrecht at the College of Public Health. We're actively involved in NACHO's Policy Improvement Program. It's a 2-year learning community, which has been another great space for peer learning and idea exchange. And finally, really working on partnership and collaboration engagement. So staying connected with local and state initiatives. There's many different task force and collaborators in our community. So we're making sure that our team is involved in supporting the work that is already going on, as well as when students that are doing work in the MCH space approach us about ideas that they want to do that aligns with the work that we're doing. We're also open to working with them.
So I just want to end with this. When you know better, you do better. So we've come a long way in 11 months, really rebuilding trust, creating structure, and laying the groundwork for something that can last. But at the heart of this, again, it's not just about programs and meetings. It's really about families. And I can speak for myself that I'm really grateful to do this work alongside Diana and Akshay, who also bring compassion, insight, and commitment to this work. And I just wanted to thank you guys for taking time to hear about the work that we're doing. Does anyone have any questions?
Maybe not a question, but a comment. I want to commend you on the interviews and how hard that must be and what kind of a special the special type of person it takes to be there for those families.
Thank you.
And to get them the resources that they would need to help.
Thank you. It's
amazing
really,
that you
it's a
guys do
sacred
that.
space, and it's an honor to be in that space.
Yeah, yeah.
So thank you.
Can you all go back? It was the slide that came up when Akshay was presenting. It had like the mind mapping stuff.
Oh,
Okay. Tell me, what do you anticipate under particularly the economic and social systems section? What have you all been hearing with the potential changes that may come to Medicaid? How do you think that may affect?
honestly, I just got an update from one of the maternal policy centers that for now it says that Medicaid as it pertains to the perinatal period will be unaffected. But one of our goals yesterday in our recommendations is the care navigator role, is to also reduce barriers to connecting people with these applications, because we know that the applications are tedious and the system, as somebody said, is working as it's intended to. Like, it's supposed to be difficult to get these services. And so we're trying to reduce barriers to at least apply to those services as it pertains to what happens in the future.
Yeah, I think, thank you for your question. I think we also recognize that, Nebraska's Medicaid expansion was a great example of how we leverage Medicaid expansion to provide greater access to birthing people and families, to extend Medicaid coverage for 1 year postpartum. I think that we recognize that there could be potential impacts in the future in continuing to allow for that expanded access to care and coverage, and that our role and responsibility in this is to continue to convene a space for people to speak to the potential impact of changes, and a mind for looking at the fact that multiple systems interact in multiple ways, and that a family's inability to access care because of a loss of potential coverage can have a ripple effect throughout these other systems. So it has come up. We talked about it yesterday in our case review team meeting while we were prioritizing, because the reality is one of the greatest examples of the impact of expanding Medicaid expansion in Nebraska is the fact that we've allowed for birthing people to retain their access to care for 1 year postpartum, and we don't want to see that go away.
So it's on your radar, and you're gonna keep track of it.
Absolutely. I also think this is a great opportunity to highlight the fact that a big part of our role and responsibility is to look at upstream policy and legislative impacts, and our opportunities to engage in that, to have a broad public health impact that improves health outcomes. Our ability to build capacity and knowledge around legal epidemiology and targeted and intentional policy scan and policy review to provide those levels of recommendation and support in decision makers making timely decisions that have a meaningful impact is probably well leveraged in this space now as we continue to expand that capacity and the knowledge that we've been able to build and move it into the maternal and child health space.
Okay.
Does the current situation with SNAP have an effect on
Absolutely.
this?
It does.
Could you share a little bit about that?
Yeah, I think this is a good illustration and not an exhaustive picture of the interaction that exists between multiple systems. I think if we had a systems map that was accurate and truly reflected the interaction, it would be far too large to display. The reality is, we are trying to look at the broader social factors impacting a family's ability to thrive and a baby's ability to survive to their first birthday and make it to kindergarten. If they lose access to SNAP benefits, if eligibility criteria change and it is no longer a possibility for a family to access WIC, those kinds of things are going to have long-term negative impacts on the family and on our communities as a whole. So I think we have to recognize the reality that reducing access to safe and sustainable foods is going to have a very dramatic impact on birthing people's ability to carry babies to full term, and then babies being born at an appropriate birth weight. So I think we're going to see an increase in the number of babies born at low birth weight, and we're going to see some pretty stark and noticeable long-term negative health outcomes as a result of these changes. Yeah.
Awesome work, each and every one of you, and seriously, this is phenomenal how you've taken this over the last year. So thank you, and thanks for the update. Are there plans for like community share out, since you have more real-time data about some of the issues going on and potential solutions?
That's one of the processes that we're working on as we work on our community action team, is figuring out how we share information broadly to the community, not just those who are involved in the program. We have taken into consideration that maybe people can't be involved in our program but have the capacity to make change in their workspace, that we want them to also know about some of the themes and findings so that maybe they can make change internally too. But that's a process that we're trying to figure out, how do we move those findings broadly into the community.
Appreciate it. Good
Thank you.
work. Thank you all.
Thank you.
Let's move to item B, which is the epidemiology emergency preparedness administration.
I'll let Heather do it. Good morning, everybody. Can't believe it's July already. I am filling in for Dr. Hughes today, but I'm going to start with my division and give you an update about that. But before that, I do want to congratulate Jamin and the FEMA team for all the hard work that they're doing. I've just started participating in the FEMA meetings, the case reviews, and I am so impressed with the work that they do. I think it's incredibly vital to our community that we continue this great work. There's been a lot of advancements. I think the systematic collection of data is huge, because we should be able to take that data, we should be able to apply that to policy and hopefully make some real changes. So to kind of answer Dr. Jones, your question, and Dr. Wilkin, you know, the March of Dimes gives us a D rating in low birth rate or low birth weight in the state of Nebraska. So I think the SNAP benefits is very unfortunate, and definitely agree with what Jamin was saying about that.
The March of Dimes gives the county or the state a D rating?
That's a state. Yep. Okay, so my division, though, infectious disease epidemiology, emergency preparedness, finance, and everything else that falls under being deputy health director. So we'll just get started here. We're going to start with the Office of Infectious Disease Epidemiology. I think it's been pretty impressive that in the time that I have been with the health department, we've grown this section from 6 people to 12. You can see all of our amazing epidemiologists, our disease investigators, our administrative assistant, and our supervisor, Chad Wetzel. He's actually here with us today. We're working on filling 2 positions. We have 1 public health nurse position open for our tuberculosis program, and we are going to hire a 3rd epidemiologist again. I think the demand for the department is there as this section continues to move more into not just infectious disease or disease control, but also health data across the department as we continue to assist all divisions and sections. A little COVID update. This is probably my least favorite. You probably all understand why, but COVID in Omaha, Douglas County, and even Nebraska is low. If we look at the epidemic statewide, it's not changed much. You can kind of see the last 3 years here. It seems that each year case numbers continue to fall. That could be due to a number of factors, or less people going in and being tested. We know that the infection is less severe. We don't have the hospitalizations. We don't have people needing ventilators, things like that, because vaccine, because of natural immunity, those sorts of things. But we are seeing upticks in the southeast and southwest region of the United States, which might be the first indication of a summer wave. So we're kind of waiting to see what happens there. ACIP's, that group has been reformulated, if you will, under the new administration. So we're waiting to see how that will affect the recommendations for COVID vaccine, thinking that's probably going to be a monovalent vaccine and really targeted at high-risk groups. Respiratory season, this last season was pretty severe. We had just over 8,000 cases reported. It was the worst year since 2017 and 18. But currently, as we would expect, numbers are low for influenza. We do have some influenza activity every summer, and we continue to watch that. RSV season was also a mild season, thankfully, hoping that is due to the vaccine that's been around, I think, for 2 years now for infants. But the season peaked in February, and activity remains low there as well. Just want to mention, we were watching H5N1 or avian influenza really closely. The CDC is they no longer consider this an emergency, because we are seeing less animals and humans being infected, so the risk to humans still remains very, very low. Pertussis. It was an awful year for pertussis in 2024. My daughter even was diagnosed with pertussis, and it was horrible to watch her, so I can't imagine having infants or toddlers with pertussis if she's 18 years old. But we had 245 cases reported, and that was from August until the end of the year. That was more cases than we've had in a decade or even longer. We saw that 88% of those were among school-aged children, and 69% or almost 70% of those were in West Omaha, mostly in Millard, Elkhorn, and Bennington. We can't draw any conclusion that this is due to under-vaccination, but data suggests, but it's hard to tell the difference between someone who's had a single dose of pertussis-containing vaccine and somebody who's up to date with the data that we have. So recommendation would be to make sure that you're up to date on your pertussis vaccine, as we're still seeing low levels of transmission in the community and we're still receiving cases. The team was extremely busy. I think we had just over 20 outbreaks in schools, and that resulted in 200 exposure letters being sent to families and to extracurriculars. Measles. We've all been watching the measles outbreak occurring in the United States, but not just in the United States, but worldwide. Just last week, I believe it was, CDC updated their numbers, and we have 1,288 cases in 38 jurisdictions. And that's, excuse me, more cases than we've had since the CDC has declared measles eradicated from the United States. So I'm not quite sure when they consider it no longer eradicated and when they'll change that, but we're keeping a close eye on the measles situation. A lot of those cases are happening in the central southern part of the country. Texas, New Mexico, Oklahoma, and Kansas is joining in. I just heard that Iowa had their 7th case this morning they reported out. So in Nebraska, we've had 1 case reported in the Panhandle. No additional cases were a result of that, which was incredibly impressive. I believe that this was a child who attended daycare, most likely with under-vaccinated or unvaccinated children because of their age. Continuing to watch the situation. The health department, Chad's team has worked diligently to make sure that our health alert network messaging is ready to go, that we have media messaging ready to go should we have a case. And we have received over, I know that this is an underrepresentation of what we've really received or the number of people that have been tested, but we've received at least 30 requests from physicians to test patients for measles. TB, this is another area that is not great news. Nationally, we're seeing about a 15% increase in tuberculosis in the country. And Douglas County is no different. You can see since 2021, we've been on a steady increase of cases. 2024, we had more cases than we've had, again, in over a decade. So far this year, we have 9 active cases. That's 6 pulmonary and 3 non-pulmonary. And our nurse and our staff have conducted almost 1,200 directly observed therapies, or DOTs. That's where the nurse or the staff will go into the home and actually watch the patient take their medication so that we have good adherence. And if you recall, we're down to 1 nurse, and so we're hiring. So if you know anybody who's interested in public health and is a bachelor's level nurse, please send them our way. And so far this year, we've identified 25 close contacts, and 4 of those have been identified as having latent TB infection and have started treatment. We've also had 5 DOT treatments under 5 years of age, and so those kids are at higher risk of developing active disease and developing it very quickly and severe disease, so they are put on what we call kind of a prophylactic treatment until we can rule out infection. Other updates, I won't spend a lot of time on this, but enterics, they're on the rise. It's summer, barbecues, people outside, recreation, swimming, pools, all sorts of things, right? So Campylobacter, we're seeing an increase in Salmonella. Luckily, not a lot in the world of E. coli or crypto. West Nile, so far we have no positive pools, which is pretty standard. We usually don't see that until end of July, maybe 1st of August, although I think last year we had 1 positive pool. And we have no cases of West Nile as of yet, but again, that's pretty typical. We won't normally see cases until August, September, and even into October. Yeah. Oh, cryptosporidium. So crypto, if we, whoops. So that, it's a little parasitic infection. And a lot of times we would see outbreaks in swimming pools and things. It's fecal-oral transmission, so if somebody had crypto and they were swimming, other people in the pool could potentially be exposed, right? But the filtration of those pools have come a really long way, whether it's UV or sand. Russ could probably tell you a lot more about this than I can, but we would partner in that case. So if we have a case of crypto and during that investigation we identify that they were in a swimming pool, we reach out to Russ's group. He goes out, works with the pool to make sure they hyperchlorinate or shock the pool, and then they're able to reopen safely. Outbreaks, knock on wood, it's been kind of quiet. I hate saying that. But again, pertussis last year, we had 20 outbreaks in schools and we had 1 in a daycare. So again, last fall was an extremely busy time for the team, keeping up with all of those, making sure the appropriate recommendations were being sent out, answering questions of parents and providers as well. Data modernization, I'm really excited about this, and you've seen some of it throughout COVID. We've been working on taking a lot of our data that used to be kind of in PDF formats and things and putting them into a dashboard, and we're actually going to start moving into more storyboard kind of format. One of the things that I'm very excited about is our vital statistics data, or our health indicators. That was a large PDF that people had to kind of scroll through. We were charged a lot of money to house that on our website, and we've changed all of that. We have been working closely with GIS. We have 2 of our analysts that have been trained in developing these dashboards and storyboards. And we're about to start posting some of that work that both Hong and Mira have been doing. So more to come on this, but really excited that the community can actually get in, find data, and usable data. This is another conversation that Jamin and I have been having about the femur data, since we're systematically now collecting fetal and infant mortality data, which we weren't before. For whatever reason, Jamin can tell you more about this, but the state of Nebraska does not participate in the national database for femur. And so then again, Akshay was able to recreate that. So the health department, we're sitting on all sorts of data, and I think the better we can tell our story and get that out there and empower our community, the better health outcomes we'll have. Okay, so that was epidemiology. And I'm going to move on to emergency preparedness. And I'll mention this later, but I think everybody knows Caleb Cudis was the supervisor of our emergency preparedness program. That's a newer position because I'm really looking to grow our emergency preparedness section. The rate at which we are seeing public health emergencies is exponentially growing, and there's so much work to be done in this area. One of the problems that we're facing is the fact that the federal government and the budget, we're seeing reductions in funding. So this first quarter for FEP, which is the Public Health Emergency Preparedness dollars, we're only going to be receiving 68% of that money that was allocated to us. Now, that doesn't mean that it won't be allocated later. The state of Nebraska is just kind of holding to see how all of this plays out. But it has had significant impacts across the state of Nebraska with staff reductions. I know one health director has even taken on the responsibility of being the ERC. A lot of this money pays for disease surveillance, so like Chad's section, a good part of his division or section is paid for out of the FEP dollars, and it's also delaying and diminishing response. So not great news. However, we are in a fairly good place. So I'm really happy to report that through really strong fiscal management and in working with our community partners like Sherwood, we've been able to receive a grant from Sherwood for $280,000. We put this application in, and what we're really looking to do is hire another emergency preparedness coordinator that's going to focus on extreme weather events. I'm going to talk about the Casper here in a second, but you remember after the Arbor Day tornado, we did the Casper in partnership with the University of Nebraska Medical Center, and they came here and presented on that data. And Sherwood is just a fantastic organization to work with. This is a 2-year grant, but they've given me permission to extend that using some extra dollars that I have. So hopefully we can keep this position around for 3 to 5 years. The end game or the goal is to take that from a supervisor and one coordinator to 3 coordinators and a supervisor, again, looking at different funding options that we have. Also really excited today, I'll tell you about this on the next slide here. We're doing a tabletop exercise called Corn Sweat. It's an extreme heat tabletop exercise that's happening today and tomorrow. It's actually happening right now at the University of Nebraska campus. We were selected out of 10 winners. There were all sorts of applications. This was nationwide. It's a challenge hosted by NOAA and the CDC. And we brought together folks from all from the health sector, from the university, from utilities, and we put together a tabletop exercise. And that was the point of this, to submit a tabletop exercise and hopefully be chosen as one of the winners that would be funded to actually host this. So we were chosen, so we received $20,000. We have, I think, just over 70 participants today and tomorrow that are going to be at the tabletop exercise. I think I sent an invite to each of you. But again, we have attendees from local government, Salvation Army, the University of Nebraska Medical Center, nonprofits, health systems, National Weather Service, utility companies. We have other health departments attending. So I'm really excited and super proud of my, what was a 2-person team, but my 1-person team right now. So after this, I'm gonna head right over there. But really, really great work. I just want to mention this really quickly. The Casper last year, after the Arbor Day tornado, we did the Community Assessment for Public Health Emergency Preparedness. That's the Casper. It's a rapid needs assessment. The purpose of it is to be boots on the ground and collect household level data about what folks need during a disaster. What we wanted to do is come back a year later and see how the recovery was going. And so this year we surveyed 2 counties again, Douglas and Washington, the 2 hardest hit counties. We used census blocks just like we're supposed to according to kind of the way the Casper's laid out. And we ended up sampling more than 455 residents. This year's Casper focused on household demographics, emergency preparedness, housing stability and recovery, lifestyle changes due to the tornado, mental and physical health, and stress management. We're still analyzing the data, so this is very preliminary. We need to weight it, but you can see just some barriers to recovery or repair. I think it's close to 40% are referencing some sort of financial instability, either being uninsured, no FEMA assistance, or slow to receive the money from the insurance companies. So 40% of people, again, affected by the tornado that we surveyed are still having difficulty in rebuilding. Some other notable results really around children and the tornado. We're seeing a lot of anxiety, nightmares, and sleep issues related to tornado fears and disrupted sleep, triggered by sirens, routine disruptions with missed school, extracurricular activities, etc. So again, the plan is to bring my colleagues back from the College of Public Health to present on this data once they're done analyzing it all. But we are still seeing long-term impacts of the tornado itself.
Western Douglas County School Districts, the absences and stuff.
Yeah, for the Casper, we're surveying census blocks that were affected by the tornado. So it would be households that were directly impacted or neighborhoods that would have been directly impacted. Yep. Emergency preparedness, kind of some infrastructure projects we're working on. One is the Community Reception Center for radiologics. If you remember, I'm also doing this as part of my dissertation, but we participated in 2 tabletop exercises. One was with a hospital healthcare coalition. Another one was more of a national kind of tabletop exercise called Thunder City. And at both of those, it was identified that nobody was responsible for a community reception center for an event like that. And so the health department made the decision to be leaders in that space, and that is going very well. The plan should be completed by December of this year. One of the other things that we need to do is work on our points of dispensing, or our pods. I think that this is the structure that is most often implemented in a public health emergency. You think pods, you think distribution of medications for anthrax, right, is what we used to focus on a lot. But this kind of framework has been used for COVID, it's been used for influenza vaccine distribution, it was used for the tuberculosis response in Bennington. But one of the things that we're facing is we've had a lot of turnover in the department. And so we're rebuilding this pod structure. We're working with our management team, or we'll start working with our management team to identify employees that can fill certain roles. We'll start doing trainings and things like that, and then holding a full-scale exercise and actually setting up a pod and having health department staff run through that. Okay, totally switching gears here to the finance update. Couple things. 2 of our accountants, Don Ritalin and Nate Lopez, attended the National Government Finance Officers Association Conference. Let me tell you, I've been to it. It's super exciting, but very, very important. They cover a lot of uniform guidance. So how do we handle grants, things like that. So very happy that they were able to attend. I'm extremely proud of our finance office and the way that we handle our finances for the department. Jerry's been working on updating our cash handling policy for the county's yearly audit that's coming up. We're preparing our billing for the month of June. And then the county updated their grants and purchasing manual. And so that should be approved by the county board on July 29th. And then we have a lot of work to do making sure that our policies and procedures fall in line with the new manual. I think in your packet you received the 2025 year-end closeout. I don't have much to say about this other than we came in under budget, which is always a good thing, by about $500,000, a little less than that. But right on target of where we typically want to be to make sure that we don't overextend beyond our approved budget. And with that, I am happy to take any questions about the division.
Thanks, Justin. Just back to today's exercise for a moment. I saw the pre-information on that, and it sounds like, the intention is to prepare for an instance where we might have extended heat in the community, and how are we coordinating in terms of a health system and public health needs and cooling centers and things of that nature. Yep. Can you just talk about that a little bit more, what you hope to get out of today's exercise and where you think that should go?
Oh, boy. Well, I hope that we're being proactive and bringing all of our partners together and identifying gaps should we and when we have an extreme heat event. So I think my biggest hope for this is to get the conversation moving. I know that the city of Omaha has been working on their climate change plan, and so we're hoping to be a part of that and be a real resource for the community. Again, public health, we can't do everything by ourselves, so it's extremely important that we start to build those relationships and prepare for future events.
Okay.
Yeah.
And so it's a 1 day or 2 day?
It's 2 day. So today is mostly kind of educational sessions. So we've got folks from National Weather Service, the College of Public Health, and others that are presenting. And then tomorrow will be actual facilitation of the tabletop exercise that we had put together and submitted.
Okay.
Yep.
And then we'll produce some kind of recommendations at the end, or?
Yeah, absolutely. I'm happy to report on how the tabletop goes and any of the, share the after action report with you as well. Great. And any recommendations.
Yeah, thanks.
Is Whitney in that meeting?
Whitney is not attending, I don't believe, but there are folks from her office that will be there.
Okay.
I think her deputy director is attending one day, and then another one of her staff.
Is that the new young lady that's been there?
Yep.
Okay.
Yep.
Right.
She's fantastic.
What is your feel on CDC data trust now? What is your feeling on trusting CDC data now?
Trusting CDC data. Ooh. I'm not totally sure. I think if we're...
You don't have any concerns right now?
Well, it's not that I don't have concerns about trusting the data. I have concerns about the data that's available more than trusting the data that's there. I think CDC still has integrity with their data. I worry about the data that is going to continue or has already been taken down, right? Mm-hmm. So that's more of my concern than, again, the integrity of the data.
Okay. When you say it, why that the measles testing is under? Why do you think our measles testing is under?
Well, what I mean by that is we had 30 physicians or medical providers call us for assistance in determining whether or not testing was appropriate and maybe seeking approval to send that to the Nebraska Public Health Lab, right? Mm-hmm. But there are reference laboratories that can perform these same tests.
What's a reference laboratory?
So a reference lab would be like a big laboratory that a health system would send their tests to, mm-hmm. okay? Because not a lot of hospitals will have in-house molecular testing for measles. And so point being, they don't need to call the health department to seek approval. So we're not always notified of every single patient who has come in with a rash, fever, illness, and is being tested for measles.
Okay.
So it's definitely an underrepresentation. These are just the ones that we know of because they contacted us for either consultation or approval.
But even if they went that route and sent it somewhere, eventually the state would get those numbers and you'd be able to reconcile somewhere.
We get positives.
Okay.
Yep.
Okay. I'm curious, can you all, at some point, not today, I'm interested to see the vaccine trends from 2000 to now that you got 5 years. I'm interested to see how that trend line looks.
Yeah, we can definitely look at that. It's state data, and it's school-age kids, but we know that that number has fallen. I'm trying to remember if we were at 94%, I think, of kindergarten. Yep, so 94%, and for measles, you want to be at 95 or above for that herd immunity, so we're just under that. But we can definitely...
And we used to be over it, my understanding.
We used to be over it, yeah. Nebraska traditionally has always had really high immunization rates. If you remember in 2010, we had 3 cases of measles and huge community exposures, and we had no additional cases, which was fantastic, but kind of unheard of. I don't know if that would be the same scenario today.
Okay. All right. You want to go right into the
Yeah,
director's
for sure. So I did prepare a little bit of a longer report. So some personnel changes. Caleb Cuddas, he used to be supervisor of emergency preparedness. He's moved to supervisor.
Justin, before you leave, you want to put the gallery back up?
Yes, I do. How do I do that? I feel like my dad more and more. There we go. What? Okay. So personnel changes. Caleb Cuddas, he was supervisor of emergency preparedness. He is now the STI control supervisor. We have some new positions. We have Bianca Smith, who has started as our STI control secretary. Maddie Rogers is a clinic clerk. Samuel Davies is a new epidemiologist that will be starting soon for the overdose fatality and review team. And Cialanka Matthews is a community health worker in lead. So I want to just take a second and welcome all of them. We had one employee that is no longer working for the health department, and that's Vanessa Wagner, and her last day was June 26. I also want to congratulate Hong Jing on 25 years of service with the health department. Hong is unable to be with us today, but as many of you know, she's one of our data analysts, and she's responsible for analyzing and posting much of our department's health data. And she's currently working on the large modernization data project using the data dashboards and storyboards that I shared with you just a minute ago. So I just want to take a second and congratulate Hong on her many years of service. I think you might have heard about this, but the WIC office at the Center Mall is officially moving to 2801 South 88th Street. And that's just east of the 90th and Center Hy-Vee. The department is actively working with Public Properties and DOTComm to get the new location ready. There's some updating that is being done to make it a more user-friendly space. And the plan is to open that building to October 1st to start receiving clients. So really excited about that.
So Justin, the WIC office used to be out by...
This one was at the Center Mall that's moving.
Okay.
Mm-hmm.
Is that WIC office still out by Costco in that plaza, or am I way long time ago? There was a WIC office out by like 120th.
Do you know?
120th and
120th and I.
Okay.
Yep.
Okay. All right.
Our clinic, or clinical services, I think this is just fantastic and wanted to draw some attention to it, but the clinic team attended a patient access training in June to learn how to support uninsured clients to get on free PrEP for HIV prevention, and to support clients who need help with their copay. The health department started the PrEP pilot this month. That is kind of phase 1, and the focus is on high risk individuals who are interested. The goal is to start with a small population and to work out the logistics and workflow, resources, et cetera, and then expand to all of our clients. A formal social media campaign and kickoff is being discussed with partners for the end of July. So again, I think this is a huge advancement for our clinic and for the people that we serve. Health promotion in July, they were extremely busy. Sometimes I don't think they toot their horn enough, but the team advanced harm reduction efforts through multiple community trainings and outreach events. They distributed over 70 boxes of fentanyl testing strips, 76 boxes of naloxone, and other prevention tools. They also presented on the health kiosk or the vending machine project to a statewide audience and conducted key interviews for the OD2A evaluation. And they continue to expand their partnership with organizations supporting vulnerable populations. So great work there as well. In the Division of Public Health Strategy, Innovation, and Planning, our JAMINS division, we officially launched our performance management system. So excited to see that happening. This is a system structured to design to make the progress toward shared goals visible, measurable, and actionable. And through the system, we should be able to set clear organizational goals and objectives at all levels of the department, define key metrics, establish consistent communication, and identify opportunities for quality improvement. The implementation plan will be kind of occurring throughout this fall, and the goal is to have all of the metrics in the system by October 15th. Environmental health, sanitation, and sanitary engineering. There's a domestic animal or backyard chicken ordinance that has been sent to the city attorney for review after receiving feedback from the community, I think mostly through Facebook's Chicken Talk. Russ, he likes to talk about that, and should be on the city council agenda in the coming months. And this really limits backyard flocks to 10, no roosters, and folks have 5 years to comply. Another big win for the health department is in food safety and compliance. We're finally updating Chapter 11 of the Omaha Municipal Code for the first time since 1970 to align with current practices. I think the big win here is putting in a new requirement for all food handlers in Douglas County to obtain a food handler certification. The foundation, our legal team is currently reviewing a letter of engagement from a third-party attorney, which Lindsay received late Monday afternoon. And I believe that she has or will be scheduling a meeting with Commissioner Rogers to discuss further development of the foundation's board of directors. Public health wins. We actually got that data back. You'll be hearing more about this, but some really, really great news. Compared to 2021, I just want to share that job satisfaction in the health department increased by 13 points and organizational satisfaction by 24 points. I think this is a significant improvement and a testament to the incredible work that's being done. And I want to thank all of our leadership team and all of our amazing employees for the work that they do every day. So with that, lots of amazing work going on. If you haven't had a chance to look at the division reports, I would ask that you do. One example that I'm extremely excited about is that our STI morbidities are all down, some of them very significantly. If we look at gonorrhea, we've seen a 32% decrease, and HIV a 43% decrease compared to this time last year. So again, really great work that team is doing. Continued success with our vending machines, our outreach with naloxone, our lead team. They reached almost 1,200 people at 9 different events where 9 different languages were spoken. And there's a lot of media coverage in those packets that you'll see. So again, I just think the department continues to excel, and I'm proud of the work that everybody's doing. And with that, I'm happy to answer any questions.
Justin, can somebody, do you all have any concerns? The press release you sent out with that change that the state made in regards to the handling food thing, I just saw that, and I can't remember the name of it exactly, but the recent change that was made in regards to handling like direct food packaging. I'm just wondering if there's any concerns with that.
I'm going to bring Adam up because he is the subject matter expert in that area.
Good morning, Adam Carlson, Supervisor Food Safety. The concern or the question was exactly what?
I'm just curious that change has been made. Any concerns or anything with the change?
So what was changed was bare hand contact with ready-to-eat foods. So ready-to-eat foods are foods that don't need to go through another process to be safe to eat. So that'd be salads, deli sandwiches. Since the late 90s, early 2000s, the FDA has had that in their model food code, that bare hand contact with ready-to-eat foods was prohibited. Nebraska has been a little bit resistant to adopt it. There's been a lot of lobbyists arguing that they think it's a glove mandate, so they think people have to wear gloves, and then when you're telling people they have to wear gloves, then they stop washing their hands. When in reality, people wearing gloves should be washing their hands prior to donning the gloves. So what the real concern is with bare hand contact with ready-to-eat foods is ill workers transferring that food or that illness to the food. So they come to work when they're ill, they don't wash their hands, and then they contact that food with their bare hands, and that passes that illness through the food to the customer. Over 50% of foodborne illness outbreaks in the United States are norovirus, and that's primarily how it's transferred through bare hand contact, along with hepatitis A and Shigella.
So when you say they're lobbying for, are they lobbying against this change, like they're lobbying against not having to wear motorcycle helmets? Because it sounds like they're making like an individual freedom argument.
Yeah, it was. I believe the lobbyists that were against it were from organizations in Nebraska that viewed it more as a glove mandate, and they were concerned, with the cost of gloves, environmental impacts of gloves. Again, they were concerned that people would stop washing their hands in lieu of just wearing gloves. So, but the state of Nebraska passed it this year, so the whole entire state of Nebraska is they're prohibited from handling ready-to-eat foods with bare hands.
Okay. Interesting. Okay. Anybody else?
With the vending machine update in the report, I just had a concern about the Plan B change, that it looks like it's been about 3 times the amount of other agencies that are providing the product here locally. So they've had to limit 1 per week. I do have some concerns just given like the timing on that medication, that you would want to take it within ideally 3 days.
Mm-hmm.
So if they would consider maybe doing 3 days instead of a week limit.
Sure. I can pass that on to Leah. I know that she was having difficulty obtaining or keeping up with the demand. And so that's why she went to 1 week. But I will definitely let her know that is a concern, that it needs to be taken within 3 days.
Okay. And probably suggests a larger problem that we have here.
What's that?
Probably suggestive of a larger issue that we have here, that
I-
we need so many Plan Bs.
Yes, would 100% agree with you.
Somebody else?
Thanks for your update.
Yeah.
With respect to, I know we got that public health report or state of presentation last month.
Yes.
And so with the CHA being completed, where are we at with the CHIP and the Regional Health Council moving that work forward?
Jamin, I'm going to have Jamin answer that for you.
Thank you for that question. One of the challenges in conducting or putting together and disseminating the CHIP when we've conducted a regional approach for the CHA is that our hospital system partners many of them have already completed and are implementing their action plans, which are reflective of what we would think of as their community health improvement plan. We are working to try and solidify our relationship with the Wellbeing Partners, who has historically served as the convener and coordinator of our regional community health improvement plan drafting and implementation process. And I know that all of the partners who make up the Regional Health Council are actively working to outline and define objectives and contracted deliverables to better solidify the work plan moving forward.
My understanding that's been happening for some months now. So as that moved forward, has there been some actual strategies or some goals that's been given to the Wellbeing Partners so that they can begin facilitating that work?
Yeah, so I will say in all transparency, the Wellbeing Partners are well equipped to do this work, and they've done it historically for a long, long time. They have a good and solid plan that they have laid out for the members of the Regional Health Council, and I think that there has been discussion as recently as yesterday around the members of the Regional Health Council approving those objectives so that we can move forward with the actual work.
It's not so much a question, just an update for my fellow board members. I know you all have been working on the public health code updates for quite some time, that then most of which have to get adopted by the city council and the city code. And we'll have our first one coming around food safety and food preparation that had first reading this week, public hearing next week, and presumably a vote on the 29th. So just a heads up that that's coming.
Thank you.
You see any drama?
Nothing yet.
Okay. All right. Thanks, Justin.
Yeah, absolutely.
We kind of blended into the reports unless there's some more questions on reports. All righty. With that, no need for executive session. And is there a motion to adjourn?
So moved.
Motion by Wilkins, second by, who's second? That's just, okay. Roll call.
Wade,
Yes.
McNally, King, Festerson.
Yes.
Jones, Rogers,
Yes.
Espinoza, Wilkin,
Yes.
and Weiss.